Hi, so we're gonna talk about some really cool uh, diseases. They are having a genetic component to it. If not genetic, then definitely it has uh, a developmental component to it. So let's directly get into it. Okay, so the first that I wanted to hit upon or talk about really quick was CMT. All right, so CMT is something called as a Charcot Marie Tooth. All right, so Charcot Marie Tooth is because of a gene, okay, CMT1A gene. All right, and CMTA1 gene is the gene that is causing the Charcot Marie Tooth disease. It's a hereditary disease that is usually autosomal dominant in type 1, okay, and type 2 both autosomal dominant. The difference is that in type 1 is the more common one because of CMT1A. It has, when you do a biopsy, you will see onion bulb formation of the neurons, okay. Second, it's a demyelinating disorder, so very important. Obviously it's a demyelinating disorder, so you want to keep that in mind as well. So it's a demyelinating disorder, so you have motor symptoms, you have sensory symptoms, and you have the lower limb affected, very profoundly, leading to something called as a foot drop and pes cavus. Pes cavus is nothing but hammer toe. So what happens is that your toe is kind of your so basically you have a hammer toe and you have a pes cavus. So in pes cavus, if this is your feet, you will have this arching of your feet. So that's basically your pes cavus, okay. Pardon the drawing. So that is CMT1. What about CMT2? CMT2 is also called hereditary sensory autoneuropathy, and CMT2 is associated with axonal neuropathy. So it involves the sensory part more. It also has certain autonomic manifestations, okay. It has numbness, but it's very less common compared to CMT 1. So that's why we remember CMT as can't move toes as disease, and it's a demyelinating disease. Once we've covered that, let's look at something called as a SturgeWeber syndrome. And SturgeWeber syndrome is a very interesting syndrome. So a regular case would be like a mother comes to you, and she's really worried because her baby, first of all, has if this is the baby's face is going to be covered. He kind of has a very big vascular malformation, and that's actually called as the port wine stain. I'm pretty sure you've heard it, or the nevus flammeus, okay. So it's a birthmark, it's a massive birthmark, okay, and it's on the cranial nerve, trigeminal, ophthalmic, and the maxillary branches distribution, dermatomal distribution, okay. And very important is that the patient has seizures, also that there is a lot of calcification, a leptomeningeal calcification, that is that it involves the arachnoid and pia mater plus pia, and there is a lot of calcification around that regions, okay. Because of the calcifications, there is a lot of seizures and epileptic episodes are seen. Second is that there is a lot of intellectual disability, and because it's a port wine and because it's a neoplastic, it's a non-neoplastic vascular malformation, I am pretty sure that you could also consider the fact that there could be an episcleral hemangioma. So episcleral hemangioma would lead to glaucoma. How come? Because if you have an hemangioma at the episclera, that basically means that there could be a raised intracranial, a raised pressure because of increased production of aqueous humor. So it could lead to glaucoma. Well, that would be increased aqueous humor pathology. But let's say if there is an episcleral hemangioma and there is an increased in intraocular pressure. Because of the episcleral hemangioma, it could directly lead to a glaucoma. So basically, there's an increase in intraocular pressure because of the hemangioma. So that is what SturgeWeber syndrome is. There are three important things. First, a baby comes, he has a massive birthmark, classical feature, and that just gives you the diagnosis that it is a SturgeWeber syndrome and there's a seizure. Second, very important, is the tuberous sclerosis complex. Now, tuberous sclerosis is autosomal dominant. It has TSC1 and TSC2. Now, TSC1 and TSC2 both lead to almost the same kind of thing. It is a tumor suppressor gene, and when this is gone, when there is there's a mutation in this tumor suppressor gene, obviously there's going to be increased proliferation and there's going to be hematomas. Hematomas are mixed tissues. Hematomas are seen in the CNS or in the skin, and you see ash leaf spots, and this is very important. They say that there is ash leaf spots is with TS and neurofibromas are with cafe Orlo spots. So you want to keep that in mind. Obviously, rhabdomyoma, cardiac rhabdomyomas are very, very important. Muscle tumors, angiomyolipoma, which you wouldn't see anywhere else, are also seen, and they are also associated with the renal angiomyolipomas. Very, very important. Also, it's associated with a lot of seizures because of hematomas in the CNS. All right. Obviously, IQ would be a little lowered at the same time, and it is certainly associated with increased incidence of ependymal, below the ependyma, and giant cell astrocytoma. So they are associated with fibromas of the CNS, with astrocytomas, etc. Very important. Tuberous sclerosis, another very important disease. Next, let's come to the NF, that is the neurofibromatosis. Neurofibromatosis type 1 is very, very important. It's an autosomal dominant, and it is associated with this particular neurofibrin. Neurofibromin gene. Neurofibromin. And it leads to café-en-loute spot, it leads to cutaneous neurofibromas, Lisch nodules in the iris, it leads to seizures, it leads to very important pheochromocytoma. Very, very important, pheochromocytoma. Also a lot of seizures again, and bone lesions are also seen relatively. So you want to keep that in mind, just that café-en-loute spots is going to give you the direct diagnosis. It's very, very characteristic of neurofibromatosis. Now they usually ask you about the second one as well now. So bilateral acoustic or vestibular schwannomas are very, very important. Second is that meningioma and ependymomas are also seen, type 2. So type 2 is relatively more simple than type 1. So you want to keep that also in mind. Finally, we have the von Hippel-Lindau disease. Von Hippel-Lindau is an autosomal dominant TSG. It's a TSG, and it controls the proliferation of vessels. So basically, you will, if this is gone, obviously you will have hemangioblastoma. All right, you will have bilateral renal cell carcinoma. Pardon the handwriting. RCCs. You will have pheochromocytoma and angiomatosis as well. So those are the important diseases that I really wanted to cover. And I think that is about it, whichever comes with the CNS. Just you need to remember, SturgeWeber is with obviously a port wine stent. TS is with ash leaf spots and a lot of hematomas. Neurofibromatosis with café-en-loute spots, cutaneous neurofibroma, Lisch nodule, and von Hippel-Lindau is associated with bilateral RCC and pheochromocytoma. Bilateral RCC is a very important point that has to be made. And that is about it. Thank you very much.